of Gastroenterology at Medanta, Lucknow. He is over Ciprotes. He served for 7 years as Professor of Gastroenterology at SGPGI, Lucknow, and he has contributed to numerous national and international research papers.
And we'll just switch gears. Since morning we have been directly or indirectly talking about liver disorders, and now I'm going to talk something about another organ system, that is our intestines. So I'll be talking, we were taught that this disease is extremely rare in our country, to the extent that sometimes our teachers told, don't make this diagnosis in exam, otherwise you will be failed because this is not found in India. Now the prevalence studies which have been done in our country are showing that the projected numbers for India, our country stands as the second largest population for patients of IBD just after USA. We are even ahead of China right now. And more patients from all socioeconomic strata we are seeing suffering from this disease. This disease can be quite debilitating if we don't diagnose and treat it timely. The treatment is lifelong. It's just like diabetes, hypertension, and other chronic disorders. So obviously we need to have a keen eye to diagnose this disease. So two major forms of IBD are known. One is called Crohn's disease and the other is called ulcerative colitis. I will be just giving a brief overview what these disorders are, in what context we need to suspect, and at a primary care level, how can we suspect and what initial investigation which could be easily available to all of us can be done, and then we will move on to the definitive investigations. So if you look at the signs and symptoms of IBD, mostly patients present with chronic diarrhea. I have written here particularly nocturnal, because this is one of the features which helps us differentiating in functional diarrhea from more organic causes. At times it can be associated with overt rectal bleeding. Sometimes it could be, bleeding can be in the form of occult blood in stool, obstruction, and at times with frank intestinal perforation. Sometimes the disease course can be very indolent and they may present only with unexplained weight loss, mild feverishness, weakness, perianal pain, rectal urgency. In 10% of patients, you may get a family history of IBD. In children, there can be history of failure to thrive. At times, it can be an important cause for anemia. I'm sure all of us must have seen patients who are anemic and iron deficiency anemia is there. In many patients, the reason can be underlying IBD. Also, we need to know about the extra-intestinal manifestations of IBD, the most important of which is arthralgia or polyarthritis. Patient may come with low backache, multiple joint problems. Besides, patients may have joint problems for many decades. They may be treated as rheumatoid arthritis, but after some time we realize, no, this was not rheumatoid arthritis, but it was IBD-associated arthritis. So we need to be aware of these symptoms. But by and large, if someone is having chronic diarrhea with weight loss, with anemia, these three are the cardinal symptoms of inflammatory bowel disease. Even children, we are seeing more and more children who are presenting with this diagnosis of IBD. There is high risk of growth impairment, and in children, the disease can often be extremely aggressive and it's difficult to control. So it's important to diagnose timely in children. The kids who present with IBD, quite commonly up to 20% would have a family history of inflammatory bowel disease, and naturally they have got their own psychosocial considerations. Now, the symptom complex that I told, you will agree that these symptoms can be present in variety of other disorders also. The closest differential comes is irritable bowel syndrome. So a very low or very early form of inflammatory bowel disease can present what we commonly call as IBS-like symptoms. So we need to differentiate between IBS and IBD, and I will come to that point because that's a very important differential diagnosis here. Other differentials include infectious colitis, but infectious colitis usually has got a limited course. Traditionally, we believe if someone is having diarrhea more than 4 weeks, then unlikely that patient would be having the infectious colitis or infectious cause. tuberculosis left aside. Ischemic colitis, microscopic colitis, other forms of infection, these are rare diagnoses that patients can have. Celiac disease, lactose intolerance, these are some of the differential diagnoses. But by and large, the biggest problem is differentiating whether the patient is having indolent functional diarrhea, which we often refer to as IBS, or patient is really having inflammatory bowel disease. Now, if you look between IBS and IBD, both are chronic disorders with fluctuating course. The patient would have intervals when the symptoms would be quite severe, and there would be prolonged remission periods also in both these disorders. In IBS, there are no serious consequences, and mostly the treatment rests on symptomatic treatment. Whereas in IBD, if you don't intervene early, patient can have debilitating disease. So how you differentiate? So we have to look at certain features like weight loss, anemia, any significant abdominal pain, and then we have to bank on certain investigations which I will be coming on. So we call these as red flag signs. So what are red flag signs? Anemia, weight loss, significant abdominal pain, extraintestinal manifestations. If these things are present, then most likely you should go ahead and investigate whether really your patient is having IBS or patient is suffering from IBD. So screening and diagnosis, because this is the most important message from my side to the house. In which situation and what can be done to diagnose IBD? As I already told the history points, then I will cover something called fecal calprotectin. It's a, I won't say new test, but fairly new test, which can be easily done, and it acts as a very good screening tool to rule out, an objective screening tool to look for inflammatory bowel disease. And then if still doubt persists, we can go ahead with the CT scan or MRI of abdomen. We go for specialized tests like CT enterography or MR enterography where suspicion is strong enough. And these three things, the detailed history, fecal calprotectin and CT MR, I think any one of us can get these things done. And if we have these three combined together, we will have a fairly good idea of what we are dealing with, whether it's a functional diarrhea or really it's an organic thing, and what to do. Yes, if suspicion is strong or if we confirm the diagnosis, then patient most often needs a colonoscopy. And if you are able to see any abnormal mucosa during colonoscopy, biopsies have to be taken. At times the disease cannot be diagnosed even on colonoscopy, but suspicion is high based on radiology. You need to look at the small bowel, and looking at the small bowel endoscopically is a bit difficult, but yes, tools exist like balloon enteroscopy and capsule enteroscopy can be done in specific scenarios. So this is how you diagnose inflammatory bowel disease. A word about fecal calprotectin. It's a calcium binding protein which is released from activated neutrophils. It's a marker of intestinal inflammation. Remember, it doesn't diagnose inflammatory bowel disease. It just says your intestine is inflamed. It can be inflamed for various other reasons, like simple common causes of acute infective diarrhea can also lead to it. So the results of fecal calprotectin have to be interpreted in proper clinical setting. It is measured in stool samples, and at times it's a non-invasive alternative tool for screening for patients of IBD. So remember, it differentiates inflammatory from non-inflammatory diarrhea. So I would say use this tool only if patient is symptomatic for more than 1 month. Then only this tool should be used. Coming to CT enterography. CT enterography is nothing but it's an abdominal CT where you use neutral contrast material orally to distend the small bowel. So this is important, and that's how you are able to look at the mucosal details of the small bowel radiologically. At times, a normal CT abdomen may miss very subtle changes in the intestine. That's why the CT enterography, we get it done. It's not difficult, and any radiologist can do it. So really, if you need to screen for IBD, always don't just ask for CT abdomen, ask for CT enterography. Here I have shown few of the changes. Like this is a loop of small bowel which is enhancing. You can see this in the first diagram. You can see In the first diagram, within this circle, we can see the inflamed bowel loops and the blood vessels supplying this part of the bowel loop. We can see there is hypervascularity. We call it Coombs sign. In the second picture, we can again see a target-like lesion, and that's the thickened bowel loop. And in the third picture, again, we can see this target lesion. So these kind of signs can be seen, which suggest inflamed small bowel, and CT at times is helpful in diagnosing these patients. Now, if you have a very strong suspicion based on your initial evaluation, based on your calprotectin and maybe radiological test, you have to go for colonoscopy. For ulcerative colitis, a colonoscopy is almost always diagnostic, and you will see diffuse inflammation, and there is almost continuous involvement of the colon, starting from the rectum and going upwards to any extent it can go. Similarly, the healing occurs in the opposite direction. So proximal progression is there. You will see edematous mucosa, the small, the bowel vasculature that is normally visible in the normal colon is completely lost. There will be loss of postural folds. Ulcers should be there. They can range from small superficial ulcers to very deep ulcers can be there. There would be spontaneous bleeding, and at times you can also see mucosal islets, which we call as pseudo-polyps. In Crohn's disease, the most common site of involvement of Crohn's disease is the ileocecal junction, where the small and large bowel join together. You will see deep linear ulcers, or at times it can be only small aphthous ulcers. There will be patchy involvement. In ulcerative colitis, the involvement is continuous, but here you will have segments of bowel which are involved with these findings, and there will be intervening segments which are not involved, which is disease-free. There can be stenosis. At times, the inflammation may extend outside the wall of bowel, leading to fistulae formation. Often you will see the rectum is spared. So these two diseases, commonly we combine them and call IBD, but the management is slightly different in both these scenarios. So let's take a typical case scenario. A 32-year-old male with 8 months history of chronic abdominal pain, intermittent diarrhea, occasional mucus in stool, mild fatigue, no weight loss. Examination is normal. Now, a very typical case which you may get in your OPD every day. In spite of repeating it, asking, the patient denies that he hasn't seen any blood in stool, it's only mucus. Now the clinical question is it functional or is it inflammatory pathology that you are dealing with? Upfront, it appears to be functional only. Why? Because there is no blood, there is no weight loss. So in this case scenario, obviously I would say the clinical diagnosis would more towards IBS. So you may start treatment based on the patient's symptom because you don't see any urgency to intervene here. You can follow it up, but if patient is not responding to the treatment, then you may like to investigate further. So what you need to do? Wait and watch on symptomatic treatment in this patient. You will like to go for fecal calprotectin, you want a CT scan, you want a colonoscopy. So in this case scenario, what my opinion is, you can initially start symptomatic treatment, wait for the response maybe for 4 to 8 weeks. But if patient is not responding, you may go for fecal calprotectin test, and if it is normal, by and large, you have ruled out IBD in this patient. But if fecal calprotectin is high, then you may go for colonoscopy in this scenario. Now moving on to the treatment. What are the goals of therapy of patients of IBD? The first thing is the early diagnosis. We have to diagnose what morphology of disease you are treating with. Is it ulcerative colitis or Crohn's disease? Now both this disease, if you look at the severity, you have to classify what is the extent of disease. By extent, I mean how much part of colon or intestine is involved with the disease, and the second part is severity of disease. Now severity, you look by two things. One is the clinical and biochemical severity, and the other thing is the endoscopic severity. How deep the ulcers are and what impact those ulcers are making on the patient's body, whether the patient has lost weight, patient has anemic, how much is the fecal calprotectin, what is CRP, ESR levels. By this we assess the severity, and then we look at the endoscopic severity. Then the next goal is how early we can achieve clinical remission. That is, you can make the patient symptom free. Once you have made symptom free, the next goal would be the symptoms should not recur. That is, your remission is achieved for prolonged duration. And the final goal would be to prevent long-term complications and long-term complications of the disease like fistulae formation, malignancy and all. Now, there has been, in last 2 decades, the major change in concept has occurred in IBD management is you have to intervene early and fast. Why? Because initially the treatment was focusing on symptomatic improvement. If patient is having diarrhea, anemia and weight loss, the treatment was focusing only on make patient symptom free, correct his anemia, correct his diarrhea. And if you are able to do it, that's good enough. But people realized even if clinical response is there, there is a significant chunk of patients who used to progress and still land up with complications like stricture formation, bowel perforation or abscess formation. So the shift gradually occurred from clinical response alone to something called as mucosal healing. Mucosal healing means on endoscopic vision, the mucosa which was abnormal to begin with should normalize. Because if you are able to achieve mucosal healing, then only you are able to prevent future complications. So don't just get satisfied by the clinical improvement alone. Why this is important? Because many times patients as well as sometimes doctors too tend to underplay things that okay, symptomatic response has occurred, so nothing needs to be done, we don't need to escalate treatment, we don't need to monitor further, we don't need any sort of invasive test to look for improvement, and we assume that since clinical response is there, so andar bhi sab theek ho gaya hoga. But many times this corroboration is not there. Why is it important? Because the natural history studies have already shown that if you miss the initial window of opportunity, then patient would land up with certain structural changes which would be more or less permanent, and it would be really difficult to reverse those changes from that stage. A typical thing like rheumatoid arthritis, if joint deformities have already occurred and then you are going to intervene, then it's become difficult to correct those joint deformities. So you have to intervene early. These are the targets of treatment. Obviously, the short-term target would be symptomatic response and symptomatic remission and normalization of biochemical parameters, CRP and fecal calprotectin. However, in long-term targets, your target has to be endoscopic healing and normalization of quality of life and absence of any disability. So, long-term target always is not clinical remission alone, but achieving mucosal healing. Now, what are the factors you consider while you decide what drugs need to be given? It's like diabetes, you have plethora of drugs available with you, and you don't use one drug for every patient. You look at various factors and then choose what drugs have to be given. So for drug, you have to know what is the age of the patient, what is the extent of disease in my patient, and what is the severity of disease. Obviously, these 3 things are the major determinants which would guide what treatment needs to be done. Obviously, then patient preferences, finances, extra-intestinal manifestations are there or not, and then while using immunosuppression, you have to look at the safety profile like secondary infection and risk of cancers in these patients. These are the traditional treatment options that were available. Corticosteroids. The corticosteroids can be the traditional prednisolone, hydrocortisone, or we can use budesonide. Budesonide is a topically acting drug, and nowadays its use is becoming increasingly common. So we have both preparations of budesonide, one which acts in the small bowel, and now we have a preparation available which also acts in the colon. So depending on the site and extent of disease, you may choose your preparation. Budesonide has got very high first pass metabolism, so systemic side effect of corticosteroids are very little. Aminosalicylates are the cornerstone of treatment, at least in ulcerative colitis, because that's the backbone of treatment for ulcerative colitis patients. Not much effective in Crohn's disease patients. So no major side effects have been noticed, and it's absolutely safe to use them for extremely long run. Then to maintain the disease, not for inducing remission, but to maintain the disease, you need certain immunomodulators. Azathioprine, 6-mercaptopurine and methotrexate. These 3 drugs have been widely used for almost 40-50 years for this group of disorders. And most often these 3 drugs, one of them, biggest experience is with, I will just finish in 2 minutes. azathioprine and methotrexate have been used for long duration. Yes, you need to look for bone marrow suppression, hepatotoxicity and other things. Now we have certain new drugs available. We call them biologics and small molecules. We have adalimumab, infliximab, which target the TNF, which are TNF inhibitors. The risk with these drugs are reactivation of tuberculosis, and real life experience says that tuberculosis can get reactivated if you use these drugs in 7 to 8% of patients. So you have to do dedicated screening for latent tuberculosis before using these drugs. You have vedolizumab, which is slightly safer but a slow acting biological, and then you have other ustekinumab drug available with you. We are happy that now we have oral small molecules which have shown good promising results, tofacitinib and upadacitinib. These two oral small molecules are available with us for use in specific case scenarios. So in summary, IBD is a common problem characterized by chronic diarrhea, pain in abdomen and GI blood loss with malnutrition. In early stages, differentiating it from IBS can be difficult. A good clinical evaluation combined with fecal calprotectin test are helpful in diagnosing IBD. And early effective treatment is key to prevent complications, and the treatment often is lifelong. Thank you.
The standard tuberculosis confuses with Crohn's disease.
So it's a common clinical problem, and believe me, there is no way by which we can differentiate with surety whether we are dealing with Crohn's disease or tuberculosis. Yes, there are certain suggestive features, like if someone has past history of tuberculosis, has contact with active tuberculosis case, has pulmonary lesions, Bontuch's test is positive. There are large lymph nodes associated with intestinal lesions. There you can suspect that likely patient is you are dealing with a tuberculosis case. But at the end of the day, if confusion persists, most of the guidelines say before starting the treatment for IBD, give a trial of ATT in these patients. So if you start ATT, you have to look at the response to ATT, not just based on the clinical improvement, but you have to repeat the colonoscopy, look at what happened to the ulcers which were present in the intestine. If they are healing, or they have completely healed, let's say in 8 weeks of ATT, most likely you are dealing with tuberculosis. If not healed at all, then most likely you are dealing with Crohn's disease. You may stop ATT there and start treatment for Crohn's.
It is always a dictum. You must consider a rare presentation of a common disease rather than a common presentation of a rare disease. So anti-tubercular treatment will be given a good trial unless proved, and specifically if we cannot investigate in our setting.
So right now there is no investigation which can say it with surety that this is tuberculosis and this is Crohn's disease. So most often we turn up given ATT first.
Any more questions, please?
Biopsies may, we know biopsy would be 100% sure only if it shows AFB, and we know that's quite rare. So if you get very large caseating granulomas, well-formed large caseating granulomas, that goes in favor of tuberculosis. Again, this is also not 100% sure. Crohn's disease also shows non-caseating ill-formed granulomas.
Thank you, Dr. ABHAI.
Is there any predisposing factors or any prophylactic measures patient cannot develop the IBD?
So right now, I would say there is nothing like preventive measure for it, but what epidemiological studies have shown that as the society advances, as you move from a developing country to a developed country, the frequency of IBD increases. So maybe it has something to do with as the load of infective diseases reduces in the society, which we are seeing now. Less of diarrhea and classic cholera epidemics, now you don't see. The frequency of IBD increases.
Any more questions?
Maybe ultra-processed food has something to do with it. Have use of, but that's again, as the society progresses, your consumption of the ultra-processed food items increases. So these are more of hypothesis, but.
Thank you. We will, one more question, please. As we are running short in time, we want.